Welcome everyone, and thank you for joining us for this session today. My name is Caitlin, and I'm the Policy Engagement Manager here at Matriarch. And shout out to Cameron, who's here for Matriarch as well, our data and policy fellow. She's providing a lot of tech support on the back end. Matriarch is a women's public health think tank for those of you who don't know us. Our goal is to normalize and broaden conversations about women's health through data storytelling, policy evaluations, and educational events like this one. As most of you are probably aware, the state of Oklahoma increased the income threshold to allow more pregnant residents to qualify for Medicaid and expanded the postpartum coverage period effective the beginning of the year. So we're here today with a panel of experts to get into the details on this change. First, we'll get some context, and then we'll dive into the nuts and bolts. And at the end, we'll have plenty of time to answer your questions. Before we really get going, a little bit of housekeeping. If you have any questions during the presentation, you don't have to wait. There should be a space to submit questions on your screen. And after our presenters finish up, we'll have our panelists answer as many as we have time for. And the session will be recorded, so don't feel like you have to aggressively take notes. We'll send this out after. Now, without further ado, here's Emma Morris, policy analyst with Oklahoma Policy Institute. She has previous experience as a case manager with justice-involved individuals and was a mentor for youth in her community. Emma holds dual bachelor's degrees in women's and gender studies and political and nonprofit administration from the University of Oklahoma. And she is currently pursuing a Master of Public Administration degree from OU Tulsa. Incredible. She's researched and written extensively on Oklahoma's Medicaid situation, and so we're super grateful to have her here with us today. Take it away.
Great, thank you, Caitlin. Cameron, if you could unshare, perfect. Okay, I'm going to share. All right, so yes, as Caitlin said, my name is Emma Morris. I am the Healthcare and Fiscal Policy Analyst at the Oklahoma Policy Institute. And we are a nonprofit, nonpartisan think tank that works to advance equitable and fiscally responsible policies in Oklahoma. So really, we're just trying to, work towards an Oklahoma where people want to move here, where people can thrive, and where everyone can really excel here in Oklahoma. So without any other intro, I'm going to go ahead and move into the presentation. Today, I'll be talking about kind of the context around maternal health and women's health in Oklahoma, as well as I'm going to try to help everyone understand what our Medicaid coverage has looked like in the past, and kind of some of the changes that we've made, or that OHCA and Trailer and the great people at the agency have made in Oklahoma in the last few months. All right, let me figure out how to move my slide. There we go. Okay, so yes, Oklahoma, unfortunately, ranks pretty poorly when it comes to women's and maternal health, as how we compare to other states. That might not come as a surprise to a lot of you who work with folks who are impacted by different policy systems in Oklahoma. But just so we're all kind of on the same page, do some table setting. Oklahoma has been ranked 40th across the states for maternal mortality rates. And the rate, I believe, in 2021 was 23.5 deaths per 100,000 live births. And it is nearly double for Black Oklahomans and for American Indians in Oklahoma. So we're really kind of fighting an uphill battle with that. That's a really significant number, and we know that we can do better. Thinking more about the postpartum period after people have given birth, we do have 88% of new moms in Oklahoma who are able to attend their postpartum visit. And that sounds really high, but we have to remember that still means 1 in every 10 are not getting that visit. And so they're not getting the screenings and the care that comes with that visit. And again, that number is worse for Black moms and for new parents without a high school degree. And then we also have 16% of new parents in Oklahoma who are experiencing postpartum depression. But unfortunately, only a little more than half are being screened for that depression. And so we don't fully know the scope of how that is impacting Oklahoma. And then finally, Historically, we have been ranked pretty poorly when it comes to the uninsured rate, and specifically the female uninsured rate. This number is, we were ranked 49th. This is pre-Medicaid expansion. So we just don't have enough data at this moment to say where we are now. We know that we are probably better, but we still have a long ways to go to make sure that everyone can access the care that they need. And I've talked a lot about the parental side of things here, how are new parents impacted by, how are new parents able to access healthcare and impacted by healthcare in Oklahoma. But that also has really rippling effects, right? So that impacts the family, that impacts the new baby, all the children, and, you know, generally economic security and all of that. So we know that a lot of folks are struggling, and we could be doing more to help them. So this slide is going to show you, well, let me back up and say, when I've talked with different people about pregnancy and postpartum coverage, people are often, it's just kind of hard to wrap your mind around all of this. There's so many different numbers and lots of different coverage options. So I just wanted to kind of show this to help everyone understand kind of where we were before this extension of pregnancy and postpartum coverage. So what this graph shows you is the annual income eligibility limits that people have to be under in order to get Medicaid coverage in these areas. These numbers are for a 3-person household. So before we extended this pregnancy and postpartum coverage, there were kind of 2 options to getting pregnancy Medicaid coverage. There was a full benefits pregnancy package where folks needed to be making about $32,000 a year or less for that 3-person household in order to get the full benefits pregnancy coverage. And that, you know, has the coverage that you think of when you think of healthcare, right? So primary, specialty care, dental care, mental health treatment, all of that. And that came with 2 months of postpartum coverage. There was also another path, and still is another path to pregnancy Medicaid coverage, and that was through the limited scope pregnancy package. So that was, I keep saying was, that still is available, and it's available at a slightly higher income limit, more like $48,000 for that 3-person household. And that still, you know, provides really vital coverage, but it's slightly more limited, and it does not have postpartum coverage this to the same extent that folks in the full benefits pregnancy coverage package are able to access. So this next slide kind of shows you, so we are at, you see right in the middle, Oklahoma, we are at 138%. Pre-extension, we were at 138% of the federal poverty line was what you had to make less than that in order to get the full benefits pregnancy package. And as you'll see, there are only 4 states, including Oklahoma, whose income limit was that low. Lots of other states were covering people at higher rates during pregnancy, at higher incomes during their pregnancy and postpartum period. And so we kind of identified this as a gap, right? We could be doing more to provide full benefits coverage to more pregnant people in Oklahoma. And so I'm just going to generally kind of show you what we have done. And then, of course, Traylor will go much more into the details. But this slide just kind of shows you like kind of what the change is. So this is post extension of pregnancy and postpartum coverage. You'll see the middle bar in the graph previously was lower, right? You had to make less than about $32,000 to get that coverage. And now that full benefits pregnancy coverage is available at higher income levels, and it includes 12 months of postpartum coverage rather than 2. Notably, and very importantly, the limited scope pregnancy coverage is still available, mostly for folks who don't meet citizenship requirements. It's a very vital program, and now we have just a more expansive way for people to qualify for this coverage. And then lastly, I just think it's important to talk about this as well. You know, why do we need the pregnancy and postpartum extension? Why is this so important for Oklahoma? And of course, I'm sure that Traylor and anyone at OHCA can probably talk more about, you know, the actual impacts that we're seeing, but I can talk a little bit broadly about what other states have experienced and what we know from research and that kind of thing. Generally, increased access to coverage, particularly during and after pregnancy, is just really, I mean, it's really life-changing, right? So it means better access to primary care, specialty care, mental health treatment, dental care. It just generally means better health access and better health outcomes for people in that period. The other great thing about this 12 months of postpartum coverage is that coverage is continuous. So that means that folks will be able to keep that coverage for a full 12 months after the end of the pregnancy, even, you know, if their income fluctuates because they picked up an extra shift or something like that, they'll be able to, they won't have to worry about losing that coverage for those kind of reasons. And so they'll be able to have that better continuity of care that I certainly, and several, that I certainly take for granted. I'm sure a lot of us do too. Tripping over my words. And then lastly, you know, generally when we invest in preventive care, things like primary care, things like expanding access to Medicaid and insurance in Oklahoma, we see state savings because we're able to take care of issues as they arise rather than treating them as they get worse and eventually are really bad. So yeah, I hope that was helpful in understanding kind of where we were and a little bit about where we've been or where we are now. I'm happy to take questions, but I think pass it to Trailer. Is that right, Caitlin, to talk more about the nuts and bolts?
Yeah, thank you so much, Emma. You provided a ton of background here because I think that's something that maybe some folks don't understand is like how big of a change this is and how needed it was. Next, yes, we will be hearing from Trailer. I'm going to introduce him real quick. Trailer is the state Medicaid director of the Oklahoma Healthcare Authority, OHCA, how you often, or OCA, how you often hear it referred to. After earning his law degree from Baylor University, he began his now 17-year career in public service with the state of Oklahoma, which has included several leadership roles. In his current one, he is a driver of innovation within Oklahoma's Medicaid program and is responsible for directing several divisions within OCA. He has led the planning and implementation of several state health service initiatives, including this one. So he's a great person to have here talking with us today. Now I will cede the floor to him.
Thanks, Caitlin, and Emma, for your wonderful background. That was actually great. I love the visuals in terms of the different FPLs. It's hard to explain that sometime orally. I want to start by saying thank you for having me and being able to talk on this very important change to the senior care program. And also thank you for your help and wisdom to Matriarch and the Policy Institute and to Barbara O'Brien and that organization for really helping drive this conversation. There was a lot of moments where we needed to get information, or I needed to get information really quickly to the governor's health task force as they were considering this as an option to move forward with. And I was easily able to call on Barbara and Emma and Caitlin and the various folks to say, I need help, I need data, and I need your visuals. And so you were very gracious in helping us with that. And I appreciate the partnership that went into this project. But yeah, so to kind of build off of what Emma mentioned, we were excited to implement this change actually January 1st of this year. Which was fairly quick in government speak, and I'm able to get things kind of off the ground and running. But it was, again, based off of a recommendation out of the Help Task Force, which was a governor initiative. The administration is very focused on maternal and child health outcomes in the state of Oklahoma. And so there's been a big push around making sure we have the resources we need in that area. And so we were able to get our federal authorities for our federal partner Centers for Medicare and Medicaid Services by the end of December through what we call a state plan amendment, which is essentially the state's contract with the federal government that helps fund and subsidize the federal portion of the Medicaid program. We do not yet have federal approval, but the way this works is you're able to backdate your effective date on that contract with the feds to the beginning of the quarter within which you submitted it for approval. We're in constant dialogue with our federal partners. We know there's going to be zero issue getting this approved. It's just a matter of them reviewing all the stuff and signing off on it. And we expect that to be forthcoming within the month or so. But we did go ahead and implement because we know that approval will be retroactive. So we implemented January 1st. That means If you are a pregnant mom on January 1st in Oklahoma, your income level for a family of two, very similar to what I mentioned a while ago, is $38,460. Why a family of two? As you're probably aware, we include the mom and the unborn child in the household size. So if you're a single mom, that's what the income is going to be. And then we add on for dad and other children in the household that go towards that eligibility, and the income goes up correspondingly for every member that you add. This is important. As Emma mentioned, we did have and still do have what we refer to as the soon-to-be Sooners program. There's two different soon-to-be Sooners program. There's a undocumented non-citizen option, and there's a citizen option, and they're both limited benefits that end at delivery or the pregnancy end. This is important. We still have the one option for our non-citizens, but for those that are citizens can go into this and have the full scope Medicaid benefit. You should have received a pamphlet with your invitation to this meeting. It's a good one-page flyer to disseminate or print off and hang in your clinics just for a visual for these new members. We estimate annually there's going to be about 2,500 additional moms that will now qualify for full scope Sooner Care rather than the soon-to-be Sooners limited benefit. Also, having that postpartum option available to you for 12 months continuous coverage, which Emma also mentioned, but I'll go into a little more detail with why that's important. So we did have a lot of conversations early on as we saw states beginning to expand their postpartum period fairly quickly. And we had a lot of internal and external conversations about why haven't we done that yet? And we had the conversation of, well, we have expansion. And right now our expansion income threshold was the same as our pregnancy threshold. So once a mom delivers, she can go straight into expansion and have full scope benefits, which was great, but it also left room on the table to add more. So we did. But an important distinction there is expansion members don't have 12 months of continuous coverage. The postpartum pregnancy benefit does. What that means is if you have a change in circumstance or change in income or family size or whatnot, continuous coverage means it's guaranteed for that 12-month period. If you're in expansion and we know something changes with income or otherwise that would impact your eligibility, we have to make an adverse determination on that. So if you get a new job, you make more money, and we find out through a data match, or you've updated your application, you're no longer eligible for Sooner Care. So that's a real important distinction. Why is that important from a clinic level? It helps if you can talk with your members. If you have pregnant moms in your clinic, have that conversation about their eligibility type. If they have gone in and they've chosen expansion based on their income, or they came in as expansion, then became pregnant, it's important to update that information to identify that they're in the pregnancy category. That way they'll have that 12 months of continuous coverage and don't have to worry about income fluctuations post-pregnancy. We're really excited about that 12 months. As we all know, so many health outcomes are happening, and there's a lot of important things happening in that 12 months postpartum that, Emma mentioned screening rates. I've always kind of had an internal struggle with trying to enhance those screening rates when we don't have the option of referring to treatment for identification or positive screeners, for example. So we know mom has postpartum. We know mom may be struggling with an addiction post-pregnancy, but what do we do other than refer to a state resource that is already limited in capacity? And so now we have the important ability to be able to say, you have Sooner Care now. We can refer you to any one of our contracted network providers for those treatment services for 12 months that we know of. So again, this all went into effect January 1st. We've had some questions about what happens if a mom lost eligibility, let's say in October of 20, what is even the year, of 22, and we now implemented the benefit in January, can she reapply to now get the rest of what would have been her postpartum period? The answer is yes, but you don't have to. So another wrinkle in all of this is that we have been going through our public health emergency this entire time. So since March of 2020, we have been under a continuous coverage requirement from CMS because we've been getting enhanced federal dollars because of the COVID public health emergency. One of the strings attached, a very welcome string, attached to receiving that enhanced FMAP is that we cannot unenroll anyone from the Sooner Care program, regardless of change in circumstance or income, unless three things happen. That member requests to be unenrolled, they move out of the state, or they pass away. Other than that, in order to get that extra dollars, which have been crucial for Oklahoma's healthcare infrastructure, we cannot unenroll anyone. So let's say a mom was pregnant, she delivered, she had her 60 days, it ended, we're not terminating her from the program regardless. That process for unwinding, as we're calling it, and then the CMS is calling it, won't start until April. So it's right around the corner. And it's also important to note that all of these members who have been on the program, and we estimate some 300,000 of them, no longer meet Sooner Care eligibility criteria. We will start unenrolling those members starting in April, which means May 1st will be the first day that the first subset of this group will no longer have eligibility with Sooner Care. Now we are looking at systems modifications to where we can identify moms who are within that year of postpartum coverage and resetting their Sooner Care end date such that they're not targeted for unenrollment during the period within which they would have had that 12 months eligibility. So hopefully we won't see any hangups with that. We won't see moms who would otherwise have been eligible under 12 months lose coverage. But I say that just to say, if you have clients in your clinics and they're experiencing that they lose coverage during what would have been their 12-month, call our member hotline. We will get that resolved because it shouldn't have. I've been rolling out large scale projects for a long time and none of them have been executed flawlessly. It's expected in large scale projects. As much as I would love to say I had, we know those bumps are going to happen. We don't want that to adversely impact our members or our provider network. So please call us and let us know so we can get that resolved. I'll touch briefly just because it's so intertwined on the public health emergency unwinding process. I mentioned that starts in April. It's going to be 9 months process for us, which is also the time it takes to carry a child full term. Interesting. So we will December 31st will be the last set of groups that will roll off the program. We're doing that in a very intentional and member-centered, compassionate way, such that I mentioned a while ago, we have around 300,000 eligible individuals who will no longer meet criteria. We're looking at them individually at the individual member level because we have data on all of them because of our real-time eligibility system. We know through our data pings what their new incomes are, for example, where they're employed. And so we also know based on data experience and claims data, if they're in the middle of an episode of care, for example, or if they have a chronic diagnosis that's requiring a lot of interventions, or if they've never even accessed the Sooner Care program in the 3 years that they've had continuous coverage. So those first few months, we'll be looking at those individuals, 70,000 of which honestly have never even had a claim for service. So we're targeting them for more early unenrollment because we know they're not as dependent on Sooner Care as some of our other members might be. Then we're going to look at things like, does your case, and when I say case, that's a family, we want to preserve the family units coverage. And so let's say that there's mom, dad, and 2 kids. We're going to combine that family and make sure that the most acute needs of a member in that family are met. So let's say mom, dad, and one of the children have never had a claim, but the second child has had a lot of claims for services. They will be targeted towards a later unenrollment towards the end of the process. And we'll lump that family together for unenrollment at the same time. Other factors we'll look at is, are there children under 5 in the family? That will be targeted towards the latter part. Again, chronic conditions, whether or not you have commercial insurance as a third-party coverage in addition to Medicaid or Sooner Care, those will also be kind of targeted earlier in that first, 4-month period. But we really want to make sure that folks that critically need Sooner Care are, kind of identified as a later roll-off in that process. There's going to be a very robust communication process around that. We've already begun it. I actually saw coverage on KFR yesterday evening. We have been talking with our members and communicating for the last 2 years about the importance of updating their application by going to mysoonercare.org, updating their income information and all the information necessary like change of address, updated contact info, because we're going to start sending out a series of letters to members based on when they're targeted for end of eligibility. So we're making them purple because we've been sending mailers out the last few years, and I know how it is. I get something from my insurance carrier, and I typically put it straight in the trash. But we're making them purple. Hopefully, it's will stand out, make someone want to open it. There's going to be March. We'll send one out to everyone, and then there will be a 45-day, a 15, and a 10-day prior to the individual's eligibility expiration. They will get 3 different letters. So we're hoping to contact them and let them know so that they are aware of other resources necessary We'll be ready to assist in transitioning. Of course, when members roll off the program, we will send our data file to the marketplace, the health exchange, federally facilitated marketplace, so that they can pick them up for private coverage there through the ACA. The unfortunate thing is we don't get a response back, so we don't know if they obtain that coverage, but at least we have done our part to get them that information and set them up for success on the commercial market. So I think I've covered everything, and between Emma and I think we've addressed most of the high points, but happy to answer questions when we get to that part.
Awesome. Thank you so much, Trailer. Every time you talk, it's just a fountain of valuable information. It's awesome. So appreciate you being here. And thank you to everyone, or Emma as well, both of you, really appreciate it. So we're going to open up for questions, but first I want to introduce our other panelist, Barbara O'Brien. She is director of the Oklahoma Perinatal Quality Improvement Collaborative, OPQIC. She began her career as an RN at what is now known as Oklahoma Children's Hospital, OU Health and Labor and Delivery 36 years ago. She's been at OPQIC since 2002, where she supports the organization's work advancing a culture of safety, equity, and excellence in perinatal care throughout Oklahoma. She serves on a variety of advisory boards for agencies that support work in Oklahoma women's health. If there's someone that understands like kind of that boots on the ground impact of this kind of stuff, it is Barbara. So we're very glad to have her here. Just a reminder, please be sure to type your questions into the question box on your control panel, and it looks like we have several already. So one of them I'm going to knock out quickly. It was someone that missed some sound for a minute. So when you're talking about not unenrolling pregnant women on sooner care, so you will not unenroll, and will there be a time when you do unenroll pregnant women?
Good distinction. So what we are doing is our pregnant moms will be targeted for unenrollment if they no longer meet criteria and they have exhausted their 12-month postpartum coverage. So what we're trying not to do is unenroll someone who, let's say, delivered in October, but they still had what would have been their 12-month coverage. We don't want to unenroll them, say, in April, just to say, hey, but if you reapply, you can still use up, the 8 or so months of your postpartum period. We want to avoid the reapplication process. And so we will go in and go ahead and set an end date to what the 12-month would have gotten them to. And that will now be their eligibility end date, which could be, in October. But what we're trying to avoid is prematurely ending them based on their original delivery date, but rather extend their eligibility date based on the remainder of the 12 months.
Thank you for that clarification. Next up, let's see. Will the extension include mothers currently enrolled in soon-to-be Sooners?
Yes. So, well, yes and no. So as you recall, there are 2 soon-to-be Sooners programs, one of which is for undocumented or non-citizens. Unfortunately, based on federal laws around this, we cannot cover the postpartum coverage for those non-citizens. But for the population, which is roughly 2,500 a year, that are in the citizen soon-to-be Sooners options, those will automatically be rolled into the expanded pregnancy benefit and no longer considered soon-to-be Sooners. If that makes sense.
Thank you. After the 12 months of postpartum coverage ends, the income threshold will go back down to the Medicaid expansion level, correct? So if someone wanted to continue on sooner care after 12 months, the income threshold would be lower to qualify for that.
That is correct. It will go back, right? So the pregnancy threshold is 205% of the federal poverty limit. It will go down to 138% for expansion.
All right. See what we got here. Okay. There was definitely a lot of questions about the soon-to-be Sooners thing. All right, what is the difference between the soon-to-be Sooner citizen and non-citizen program compared to the full scope program?
There are, I'm not off the top of my head, but there's a few services that don't overlap between full scope and the limited benefit, namely, mostly the postpartum benefit, because the soon-to-be Sooners ends upon delivery or otherwise pregnancy ending. So, but that's the main thing. But there's also some services that don't overlap between soon-to-be Sooners and full scope.
So how does this apply to pregnant or postpartum folks who may have recently moved to Oklahoma?
That is a great question. If they are new to Oklahoma and they are pregnant, they would go to mysoonercare.org and apply for benefits. And they are now a citizen. If they are now a citizen of Oklahoma, they've established residency. We would treat them as Oklahoman and they could apply. I want to say this is true, but we can verify. But technically, being within the postpartum period makes you eligible for services. So if a mom delivered a month ago, for example, in Arkansas, is now a resident of Oklahoma, she should apply for the pregnancy benefit under that postpartum period.
Excellent. Are there currently any other states that have even more inclusive coverage? And kind of as a secondary to that, is this the final goal for now, or are there further changes on the horizon?
Great questions. There's always further goals. So we try not to get comfortable with great achievements, even if they've been recent. So we're always looking and working with you all on how we can further improve this program. I will say that it was shocking when we had our first discussion around this, that we were in the bottom 4 to 8 of states in terms of coverage, which is not our goal. We want to be top 10 state in all things. And so by doing that, we're definitely in the top half. I haven't looked at where it puts us now. Emma, you may know off the top of your head where we're at now in terms of coverage, but we're definitely not in the bottom 10 anymore from that respect. But yes, we're looking at further ways. How can we support moms and babies? An important change that will be coming later this summer is the coverage of doula services. We'll actually be an innovator in this space nationally, as well as the state payer system, because I don't know of any other coverage in the state that reimburses for it outside of private pay. So we're super excited about that. We're also, we just recently added the coverage of low dose aspirin that is over the counter for moms because of feedback we heard from this group and others about the importance of that. We are looking at other ways as well through other remote types of technology, how we can better serve our moms in their homes and communities to ensure healthy outcomes.
Awesome. This is kind of my question, kind of to further that, but like if people have ideas for how we could do better, like what does that look like? And Emma, Barbara, I feel like y'all probably have some input there too, but how do you point out your problems? Where do you send your suggestions for innovation in this space?
Yeah, honestly, I say reach out to me, email me. I rarely turn down a coffee invitation or other kinds of gathering. We have meetings like this. I would say I love the advocacy that groups like yours are able to do. And so I would also say reach out to y'all's organizations if I could, to say just to have those ideas, because for those on the call, we have meetings at least monthly, the group of us, just to talk and brainstorm and talk about how we can improve on these things. And to date, most of those things have been put in the queue to implement. And so we love innovative ideas. We're always, we don't have the finger on the pulse of the community like you all do. And we rely on our stakeholders and community providers to kind of keep us informed on that. So I would say reach out to me, shoot me an email.
Yeah, I just want to say thank you to Trailer and the folks at OHCA who have been very responsive to the requests that we've had, and just generally overall about 1/3 of maternal deaths occur during pregnancy. Another occur either in the delivery period or within 1 week postpartum, and another 1/3 occur up to 1 year after that first week. So this will affect many of those, hopefully, that can improve their ability to receive care if they have chronic health conditions that often aren't even diagnosed until the postpartum period, such as postpartum cardiomyopathy is one. We've had issues with women with diabetes. How are they going to continue their care? Behavioral health issues, lactation services, all of those things can be very helpful during that postpartum period. And we do appreciate your responsiveness, Trailer, and I will tell you, he is very responsive. So you can email Trailer, and yeah, we are very lucky in other states that do the work that I do with their state perinatal quality collaboratives. They're always like, how do you even get your Medicaid people to talk to you? And there are a lot of issues with, you know, the providers and these kinds of groups talking to their Medicaid providers. And so we appreciate that. And we, you know, they are very innovative. We do have a very innovative Medicaid agency. And also we have quarterly meetings for OPQIC. If you go to our website, opqic.org, we have on our agenda, every meeting is an update from OHCA. So you can find out ways to stay up to date with what's going on. So I would encourage you to attend those meetings as well if you're interested. So thank you, Trailer, again, for all of your responsiveness in getting things done, because it really has been very quick. How long have you been in your position now?
Just shy of a year.
Yeah, I was gonna say, it hasn't been very long, and we started talking to you immediately.
Mhm.
This is what we want, and it's happened, so we thank you.
Yeah, my pleasure. I've got a great team.
Yes, you did.
I'll second everything Barbara said, and then also add that if there are folks on the call who are interested in healthcare policy that is maybe more broad than Medicaid or the pregnancy and postpartum stuff, but you're interested in kind of doing some advocacy or talking about ideas in this space or other spaces, at OK Policy, we have an outreach arm that is called Together Oklahoma, and they work on just kind of building power among grassroots people and advocates in order to, you know, make Oklahoma look the way that we want it to. So, and pass policies that really support working and low and middle income Oklahomans. So if you're interested in that as well, you can always email me and I will get you in touch with those folks.
Thank you all. So we have a few more questions kind of filtered in as we were having that conversation. Does the coverage help with individuals that experience miscarriages?
Let's see, could you say that one more time?
Does the coverage help with individuals that experience miscarriages?
Oh, absolutely. So the 12 months will start at the end of the pregnancy, regardless of how it ends.
Thank you. There is no question on the online application about whether a woman was pregnant within the last 12 months. How would someone from out of state or that did not go in and change their status from HAP to pregnant and request pregnancy postpartum coverage indicate that?
That's a good question. And I will follow up with my eligibility and coverage team, unless I know some of my team members are on this call. If they want to answer that by typing, that would be great too.
Yeah, if you all raise your hand, I think I can promote you to a panelist so that you can answer. But if not, we'll send that out in our follow-up email. Oh, here we go. We've got a raised hand. See if that works. Maybe not. Okay, never mind. We'll follow up with that question in the post-event email that we send out. Is contraceptive care included in this 12-month period? Is it considered under global reimbursement?
It's paid outside of the global during the.
Okay, will lactation consultants be able to bill as a provider?
Yes.
Then we had a clarifying question on the Soon to Be Sooners program. So why would a citizen be enrolled in Soon to Be Sooners instead of the full scope? Is it still income based?
It is income based. So that the citizen option will phase out once we can at the end of the PHE, because that's covered under full scope Title 19. It's simply a different avenue federally with authorities. So the soon to be sooners option is under the CHIP program, the Children's Health Insurance Program. And it's coverage for the mom for the unborn child, but technically that benefit belongs to the unborn child. So that's the rationale as to why it ends on delivery, because the child, the now sooner, because we call them soon to be sooners, has sooner care eligibility, but mom loses it because technically the coverage the whole time was for the unborn child.
Interesting. All right. How can more eligible people be made aware of these changes? It's a good one.
Good question. So it's through avenues like this, honestly. So we did create the flyers to hopefully get it out to our providers who can educate. We have conversations with our safety net clinics, like our federally qualified health centers. We've had meetings with community mental health centers and other stakeholder and advocacy groups to get the words out. We do have resources on our website for pregnancy-related services that gives more detail around income and availability of services and how all that works. We also we have eligibility, what we call agency view partners. So like some of our county health departments and FQHCs are able to do eligibility for the healthcare authority. And we have a trusted relationship there, and we get a lot of information through those avenues as well.
Pipe in. I'm not really a panelist, but I think everyone on this call can really help with that as well. Like being informed and making sure that, I don't know if there's signage you can post up in your institution, so when folks walk in, they see it.
And we are going to have a fairly robust communications campaign. We're still kind of in our soft rollout since we don't technically have federal approval yet, but once we do, we're going to really engage media, a lot more social media. So I would encourage you to follow our various Twitter, Facebook, Instagram, all those fun things as well. We push information out there.
And that flyer, yes, I will send it out in our follow-up email to make sure everyone has it. Okay, just want to make sure I understand the 12-month postpartum coverage. During that 12 months, do they only have coverage for pregnancy-related doctor, or is it all medical services regardless of DX/condition?
It's all medical services. So mom technically has full scope sooner care. So whatever we cover for adults, she would have access to.
So then this is kind of on the same vein. Pap smear, follow-up visits for UTI, URI, ETC reimbursed separately from global care, or kind of?
Yes. So the global is paid at delivery for the entire prenatal portion and birth. So after that, mom will be fee for service. So we will then start paying fee for service for all those services obtained during the postpartum period.
For annual well woman exams, will they still need sooner care referral for OBGYN from OBGYN to perform a pap smear?
We actually ended that referral requirement. I want to say a couple of months ago. We did send a provider letter out to our patient-centered medical homes as well as our OB-GYN provider network to let them know that. So for well women visits at the OB-GYN no longer require medical home referral.
So this one, we kind of talked about this, but probably could use, a little bit more clarification. Does this include postpartum doula care and contraceptive options?
It will. So I would say on the doula part, stay tuned. We've developed in coordination with these groups that are on the call today, as well as other groups. I feel like we've built a very robust doula framework that is prenatal, postpartum care, labor and delivery. All aspects of the pregnancy will be covered for doulas. There will be a certain amount of visits allowed, for example, throughout the entire pre and postpartum period, as well as labor and delivery, with various reimbursements, varying reimbursement levels there for the varying types of doula, as well as robust, a lot of certifications for those doulas will be accepted. So as we get closer to, I want to say mid-July, when it goes to our board for approval of those rules, we will be releasing what the framework looks like and doing some engagement with that provider community to work them through the enrollment process with Sooner Care.
So if we know this at this point, how will a doula enroll to be eligible to receive Sooner Care payments?
They would go through, we have an electronic provider enrollment system. If you visit our website under providers, there's an enrollment option. It's not live yet because it's not covered, but they will go there and they will need to submit, like they will need to have an MPI number, for example, which is a whole separate process. And they will need to submit proof of certification from the approved list that we will accept for doula certification. And then that will get them set up. And so we will be creating a packet for the doula providers to make it a little more easily understood on how to get through the enrollment process when we get closer.
Excellent. So questions are slowing down. Does anyone have any last minute ones from our audience? Anything that you would like a little bit more clarification on? Now is the time. Right, so panelists, anything else you'd like to get out there, say before we wrap up today's session?
I would say I know another group that does provide assistance for Medicaid enrollment are Ministry or county health departments. So, and we have been working with them on educating about this. So I think for providers, that can be a good place to use as a place to refer your patients if they need that assistance, because it can be a challenge for each clinic to keep up with all of this. So that can be a place that's available, I think, in most county health departments to help with that.
Yep.
In addition to the, going to the OHC website and things like that.
Awesome. Well, if that is it, thank you everyone, especially our panelists for making time to be here, and Cameron for keeping us running on the back end. We appreciate you all and coming together and making the time to understand this incredible change for Oklahomans. We'll send out the recording along with a lot of the materials that were referenced today. And we, again, appreciate everyone for being here. Enjoy Valentine's Day.
Thank you all. Have a good day.